Welcome to the deep dive. Today we're tackling something really complex. Figuring out the line between, everyday stress or quirks and what gets officially called a psychological disorder.
It's a really vital conversation to have, especially when you look at the numbers. Our sources point out that almost half, think about that, 46% of American adults will face a diagnosable disorder sometime in their lives.
Wow, 46%,
Right.
that's huge. It really drives home that this isn't about other people, it's about us, our community.
Exactly. It's a widespread experience.
So, yeah, the big challenge right off the bat is, how do you draw that line? I mean, feeling intense grief after losing someone, that's expected, it's normal. Having a little ritual you do, maybe just a habit.
Right. When does it tip over?
Exactly. When does it become, clinical?
Well, psychologists have figured out pretty early on that you can't just use one single sign. It's never that simple. You really need a multi-criteria approach. To get from just unusual to diagnosable, a behavior usually needs to tick several boxes.
Okay, let's break those down. There are 6 key areas, right? Where do we start?
Let's start with unusualness. Behavior that's statistically rare might be part of a disorder.
Might be, but like being an incredible athlete or a math whiz is unusual too, but it's not a disorder.
Precisely. So unusualness on its own isn't enough. It needs context. Then you add social deviance.
So this is about breaking society's rules, like the unwritten ones.
Yes, violating those social norms. But crucially, those norms change wildly depending on the culture, the time period, even the specific community. What's deviant now might not have been 50 years ago, or might be totally normal somewhere else.
Okay, that's a big one. Then there's the personal impact, right? Like emotional distress.
Yes, and this is often what brings people to seek help. We look at whether the emotional state, sadness, anxiety, anger, is inappropriate for the situation, or way too intense, or lasts much longer than you'd expect.
And that leads to maladaptive behavior, I assume. Behavior that actually harms you.
Exactly. This is about consequences. Is the behavior self-defeating? Is it causing significant personal suffering? Is it getting in the way of work or school or relationships? I mean, if your behavior is actively stopping you from functioning day to day, that's a major red flag.
Okay, and the last two sound more severe. Dangerousness and faulty perceptions.
Right. Dangerousness refers to behavior that poses a threat to oneself or others, outside of contexts where aggression might be sanctioned, like, say, certain sports or warfare.
And faulty perceptions. That sounds like losing touch with reality.
It is. This covers things like hallucinations, seeing or hearing things that aren't there, which are faulty perceptions, and delusions, which are firmly held false beliefs, like believing you're being spied on through your TV. Those are faulty interpretations of reality.
So we have the 6 criteria: unusualness, social deviance, emotional distress, maladaptive behavior, dangerousness, and faulty perceptions. But you mentioned culture earlier.
And this is absolutely critical. You have to consider the cultural context, always. These criteria mean nothing in a vacuum.
Why is it so fundamental?
Because culture defines what's normal in the first place. A behavior seen as a spiritual gift or communication with ancestors in one culture might look like a psychotic symptom in another.
And it's not just about what's considered abnormal, right? The sources said culture even shapes how distress shows up.
Yes, definitely. A great example is depression. Research consistently shows that people from many Asian cultural backgrounds are more likely to report physical symptoms, things like headaches, fatigue, stomach issues when they're depressed.
Instead of saying, I feel sad.
Often, yes. Whereas in many Western cultures, the diagnostic criteria heavily emphasize reporting feelings of sadness, hopelessness, or worthlessness. If a clinician isn't culturally aware, they might completely miss a diagnosis in someone presenting primarily with physical complaints.
That's a powerful example. It really shows why just a simple checklist isn't enough. You need a broader framework.
Exactly. Which brings us nicely to how our understanding, our models, have evolved over time.
Right. We haven't always thought about it this way. What was the dominant view historically in the West?
For a very long time, the prevailing explanation was supernatural, demonic possession, essentially. If someone acted strangely, it was seen as the work of evil spirits.
And the treatment followed that logic.
It did. Treatment was often exorcism or other spiritual interventions. It really wasn't until the Enlightenment, maybe the 18th, 19th centuries, with the rise of science, that things started shifting towards naturalistic explanations.
And that led to the medical model.
Yes. The idea that abnormal behaviors are symptoms of underlying mental illnesses, perhaps caused by biological problems like brain diseases.
Treating the mind like the body, in a way.
Kind of, yes. It was a huge step forward, bringing it into the realm of science. But it quickly became clear that biology wasn't the only piece of the puzzle.
So other models emerged focusing on the psychological side.
Right. You had Freud's psychodynamic model, emphasizing unconscious conflicts, usually rooted in childhood experiences.
Then the behavioral model, focusing on what we learn.
Exactly. Behaviorists argue that abnormal behaviors are learned just like any other behavior through conditioning and reinforcement.
And the humanistic approach, that was different again, wasn't it?
Very different. Humanists like Maslow and Rogers saw abnormality as stemming from roadblocks that prevent people from achieving self-actualization, from realizing their full potential. It was about growth being blocked.
And finally, the cognitive model, thinking patterns.
Yes, this focused on how irrational beliefs and distorted thinking patterns contribute to emotional distress and maladaptive behavior, like catastrophizing or overgeneralizing.
Okay, so we have biology, the unconscious, learning, growth, thinking, lots of different angles. How did the field reconcile all this? Did one model win out?
Not really win out, it was more about integration. The field moved towards models that could encompass more complexity. The two big contemporary ones are the sociocultural model,
Which really emphasizes the impact of society, poverty, discrimination, and cultural norms.
precisely, the external environment. And the other, which is arguably the dominant view today, is the biopsychosocial model.
The grand synthesis, you called it.
Yes. It really is. It insists that psychological disorders arise from a complex interplay of biological factors, genetics, brain chemistry, psychological factors like trauma history, personality, coping skills, and social and cultural factors. You have to look at all three interacting.
It sounds holistic.
It is. And a key concept within this model is the diathesis stress model.
Okay, what does that mean?
Diathesis refers to a predisposition or vulnerability, often genetic, towards developing a particular disorder. But the diathesis alone usually isn't enough.
It needs a trigger.
Exactly. It typically requires exposure to significant life stress, trauma, loss, major changes to actually trigger the onset of the disorder. So it's vulnerability plus stress, nature and nurture working together, essentially.
That interaction explains why two people can go through the same trauma, but only one develops PTSD, for instance.
Precisely. Different underlying vulnerabilities.
So understanding this complex interplay is crucial. And to manage all this complexity, we need some way to classify these patterns, right? That's where the DSM-5 comes in.
Yes. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition. It's the standard classification system used by clinicians and researchers in the U.S. and many parts of the world. It provides specific criteria for diagnosing hundreds of disorders.
But it's not without its critics or challenges, you mentioned.
No, it's definitely not perfect. There are ongoing debates about the reliability, consistency, and validity accuracy of some diagnoses, and concerns about potentially over-pathologizing normal human experiences. But it's the system we currently have for standardizing diagnosis and research.
Okay, so using that biopsychosocial lens and the DSM framework, let's dive into some major categories. You said anxiety-related disorders are the most common.
By far. This category includes disorders characterized by excessive or inappropriate anxiety reactions. Think things like phobias, panic disorder, generalized anxiety disorder, and OCD.
Let's take phobias, those intense, irrational feels. How does the biopsychosocial model explain something like, say, a severe dog phobia?
Well, psychologically, it could start with a scary experience. Maybe being bitten as a child, that's classical conditioning. The fear gets linked to dogs.
Okay, makes sense.
But then the avoidance keeps it going. Every time you avoid a dog, your anxiety drops temporarily. That relief, that's negative reinforcement. It teaches you that avoiding dogs works to control anxiety, so the phobia gets stronger.
So learning plays a huge role.
A huge role. There might be biological factors too, maybe a generally more reactive nervous system, but the learning component is very clear in phobias.
What about obsessive-compulsive disorder? OCD, that seems more complex than just a learned fear. You have these intrusive thoughts, obsessions, and then the repetitive behaviors, the compulsions.
It is more complex. With OCD, we often see stronger biological links, potential disturbances in neurotransmitter systems like serotonin, and differences in brain circuits involving areas like the amygdala, which processes fear.
So biological predispositions.
Likely, yes, a diathesis. But psychology, specifically learning, still plays a crucial role in maintaining the disorder. The obsession causes intense anxiety, and the compulsion like checking, washing, counting temporarily reduces that anxiety.
Negative reinforcement again.
Exactly. The compulsion gets reinforced because it provides temporary relief, even though it doesn't solve the underlying issue and often makes life much harder. So you see that biology-psychology interaction very clearly.
Okay, let's shift gears to mood disorders. These are about disturbances in emotional state, right? Not just anxiety, but deep lows or extreme highs.
Correct. The most well-known is probably major depression. This involves persistent feelings of sadness, hopelessness, loss of interest in things you used to enjoy, changes in sleep or appetite, and sometimes thoughts of death or suicide.
And the stats on this are pretty sobering, too. Over 1 in 5 adults experience it, and women are diagnosed about twice as often as men.
That's right. The reasons for the gender difference are complex and debated, likely a mix of biological factors, hormonal influences, differing responses to stress, and sociocultural factors like potentially higher stress burdens or differences in reporting symptoms.
What about the causes generally? Biology and psychology again?
Yes, there's definitely a genetic component. It runs in families. And imbalances in neurotransmitters, particularly serotonin, norepinephrine, and dopamine, are implicated.
And psychologically, I remember reading about learned helplessness.
Ah, yes, Martin Seligman's model. It suggests that experiencing uncontrollable negative events can lead people to develop a sense of helplessness, a belief that they have no control over what happens to them. This passive resignation and hopelessness can then spiral into depression.
That feeling of powerlessness.
It's a powerful factor. And distorted thinking patterns, like focusing only on the negative or blaming oneself for everything, are also central cognitive factors in depression.
When that hopelessness becomes overwhelming, we have to talk about suicide. It's linked strongly to mood disorders, isn't it?
Tragically, yes. It's a major public health crisis. Suicide is the second leading cause of death for young people, ages 10 to 34 in the U.S. And it's almost always associated with an underlying psychological disorder, most often depression or bipolar disorder.
You mentioned some risk factors earlier, higher rates among middle-aged and older men, particularly those over 65. And while more women attempt suicide, men are more likely to die by suicide, often using more lethal means. Certain demographic groups also face higher risks.
That's correct. Biologically, there's evidence suggesting that lower levels of serotonin might be involved, perhaps leading to what's called a disinhibition effect, basically, reducing the brain's natural brakes on impulsive or aggressive actions, including self-harm.
The key message here for anyone listening
Is to take any talk of suicide, any expression of profound hopelessness, extremely seriously. Don't dismiss it. Encourage the person or yourself, if you're feeling this way, to seek professional help immediately. Focus on alternatives. There is help available.
absolutely crucial. Okay, let's move to another set of disorders that seem quite different. Dissociative and somatic symptom disorders. These involve disturbances in consciousness or physical symptoms without a clear medical cause.
Right. Dissociative disorders involve a disruption or splitting off of functions of consciousness, memory, or identity. The most famous, and probably most controversial, is dissociative identity disorder, DID, previously known as multiple personality disorder.
Where someone seems to have distinct separate personalities. Why is it controversial?
Well, the primary psychological explanation links DID to severe chronic childhood trauma, particularly abuse. The idea is that splitting into different identities is an extreme coping mechanism, a way to wall off the traumatic experiences.
A defense mechanism.
Essentially, yes. However, some clinicians and researchers are skeptical. They question whether DID is a genuine disorder or perhaps, in some cases, an unintended result of certain therapeutic techniques, what we call iatrogenic, or even a form of role-playing, possibly influenced by media portrayals. There's still a lot of debate.
So a real diagnostic challenge. What about the somatic symptom and related disorders? Physical symptoms, but no medical explanation.
Exactly. People experience very real physical symptoms, pain, weakness, nausea, paralysis, but thorough medical investigation finds no underlying physical cause.
A classic example is conversion disorder, right? Where someone might lose function, like blindness or paralysis.
Yes, and sometimes, intriguingly, they might show what's called labile indifference, a strange lack of concern about their quite dramatic symptom. It's also worth noting that what many people used to call hypochondriasis is now generally diagnosed under this umbrella, often as illness anxiety disorder or somatic symptom disorder itself, focusing on the excessive preoccupation and anxiety about health.
What are the suspected causes here? Still psychological.
Largely, yes, though it's complex. Freud originally thought these symptoms were a way of converting unconscious psychological conflict into a physical form. He also talked about secondary gain, the idea that the symptom, while distressing, might also bring benefits, like escaping responsibilities or getting attention.
And learning theorists.
They might focus on how the symptoms could be reinforced, if they help the person avoid anxiety-provoking situations or gain sympathy. Again, it's likely an interaction of factors.
Okay, finally, let's touch on two categories known for being severe and often chronic: schizophrenia and personality disorders. Starting with schizophrenia.
Schizophrenia is a profound disorder affecting thinking, perception, emotion, and behavior. It affects less than 1% of the population, but has a huge impact. We often talk about positive symptoms, things added to normal experience, like hallucinations and delusions, and negative symptoms, things taken away, like apathy, flat emotions, social withdrawal.
This sounds like the ultimate example of the biopsychosocial model needing to explain things.
It truly is. It's considered the classic example of the diathesis stress model. There's a strong genetic component of biological vulnerability. We also see brain differences like dopamine system dysregulation and structural changes, such as enlarged ventricles suggesting loss of brain tissue, particularly in areas like the prefrontal cortex.
But that's the diathesis. What about the stress?
Right. This biological vulnerability often seems to require significant psychosocial stress, maybe stressful life events, family conflict, substance abuse, to actually trigger the onset of active psychosis. It needs both the biological predisposition and the environmental trigger.
A complex, devastating illness. And lastly, personality disorders. These aren't about episodes of illness, but ingrained patterns.
Exactly. These involve deeply ingrained, rigid, and maladaptive personality traits that cause distress or impair social functioning. They're patterns of relating to the world that are significantly different from cultural expectations.
Can you give a couple of examples? The sources mention antisocial personality disorder, APD, and borderline personality disorder, BPD.
Sure. APD is characterized by a pervasive pattern of disregard for and violation of the rights of others. Think callousness, deceitfulness, impulsivity, lack of remorse. Interestingly, while often associated with criminality, many people with APD traits are actually law-abiding but might be manipulative or exploitative. They can sometimes seem charming on the surface.
What causes that lack of empathy?
It's thought to involve a mix of genetic factors, brain abnormalities, especially in the prefrontal cortex involved in judgment and impulse control, and often a history of childhood abuse or neglect, which might interfere with the normal development of empathy and conscience.
And borderline personality disorder, or BPD. That sounds very different.
It is. BPD is characterized by intense instability in moods, relationships, self-image, and behavior. People with BPD often experience tumultuous relationships, fear of abandonment, impulsivity like spending sprees or self-harm, chronic feelings of emptiness, and difficulty controlling anger.
What are the links there?
Again, it's seen through a biopsychosocial lens. There's often a history of childhood trauma, abuse, or neglect. Biologically, there may be genetic predispositions and differences in brain areas that regulate emotion and impulsivity. The interaction leads to profound difficulties in emotional regulation and forming a stable sense of self.
Wow. Okay. We've covered a massive amount of ground here, from just trying to define abnormal with those 6 criteria through the history of thinking about it to the modern biopsychosocial view and these really complex disorders like schizophrenia and BPD.
It really highlights that diagnosing and understanding psychological disorders isn't about finding one simple cause or checking off a list. It's about looking at the whole person, their biology, their history, their thoughts and feelings, and crucially, their social and cultural world. It requires integrating multiple factors: distress, unusualness, maladaptation, danger, always within that specific context.
So reflecting on all this, what's the big takeaway for you listening at home? We talked a lot about how culture shapes everything, how distress is shown, what's even considered deviant. So if the lines are so blurry and so influenced by our specific time and place, here's something to chew on. What behaviors, what ways of coping or thinking might be considered normal, even encouraged in our society today, that future generations might look back on and say, wow, that was clearly maladaptive. That was a symptom of a broader issue we weren't seeing.
That's a really provocative thought. What normal struggles today might be reclassified down the line.
Exactly. Something to think about regarding our own cultural norms.
Definitely food for thought.
Yeah.
Well, thank you for joining us for this deep dive.